Good afternoon. I would like to briefly say thank you to the committee for putting on this event and inviting me to give this talk. My presentation is a Cliff Notes edition on how to prepare for a total joint replacement in the ASC setting. My three main focal points for this talk will be on the following and how working with every individual within the ASC facility is pertinent to optimizing each patient's outcome. Before I continue, I want to stress that how you prepare for a total joint in the ASC setting is very similar to that in the hospital, or at least it should be. However, you must keep in mind these patients are not staying the night. Every case must be meticulously thought out and planned. I'm confident in saying that none of the ASC facilities you will be working with can, nor would they, accommodate 5 to 7 trays of instruments and 5 totes of implants per case. You are part of a team effort in creating an efficient process for maximizing patient outcomes. Almost every patient having a total hip replacement at Innovate Surgical will have a preoperative functional analysis done through a system called OPS. Through the planning process, we have access to a customized plan, considering optimal component position and orientation, type, and size. At Innovate, we primarily use 2 stems, a neck-preserving and a traditional Kurai type stem. With the use of femoral radiodensity mapping, I know days in advance if one of the preferred stems is not an ideal fit for that patient. For instance, if a patient is scheduled for a mini hip, I will always have a Metafix on backup. But even though these are the 2 stems of choice, I always have a blade stem, a fit and fill stem, and a cemented stem on the shelf. When I say at risk, I'm not only referring to implant selection, but also implant positioning. Through the OPS software, we are able to evaluate adverse pelvic and spinal risk factors, as well as prosthetic and bony impingement analysis. Do we need to change the functional version of the cup? What if we used a lip liner or dual mobility? All of these potential scenarios are known about before walking into the OR with a game plan in mind. Finally, what technology is being used to implement our patient-specific plan? Is it CT-based or imageless? Is everything accounted for that day, and do we have additional pieces sterilely wrapped or peel-packed in case something was to fall? You can never have enough information when planning for a revision or hardware removal case in the ASC. In the hospital setting, the majority of the time, anything and everything you may need is in the core right outside the OR. As I mentioned before, these facilities do not have the capacity to store 2 full Inomed cup extraction sets or 3 types of small frags. Regardless of the procedure, be sure to obtain the operative note from the previous surgery. If you can't find one, find out who did it and what their preferences are. You must have specifically what you need for that particular implant, as well as a universal extraction set. Recently, we had a hardware removal case. Most would deem it straightforward. The hardware was put in by us. We had the op note. We knew the exact sizes of the implants. I forwarded it all along to the rep. I thought to myself, what could go wrong? Of the 3 screwdrivers delivered, none of them worked. Fortunately, we kept a universal screw removal set on the shelf, and we were able to successfully remove that hardware that day. But what if we didn't? Always have a backup plan. And if you don't know, ask. I have been fortunate to work with very talented surgeons during my career and feel like I have seen just about every hip stem implanted in the last 30 years. But every so often I'll look at an x-ray and won't even begin to know where to start. Ask. Ask your surgeons, ask your fellow reps, and even your competitive reps. Nothing is worse than taking a head off of the trunnion only to learn it's not the system you have on the back table. Work with your surgeons and the ASC staff to optimize tray efficiency and layout. This is a team effort. In the hospital setting, 4 to 5 trays for a total hip may be acceptable. In an ASC, this is not efficient for anyone involved. Work together to decide what in these trays is needed to successfully complete that procedure. I'll touch a little more on this in a few slides, but you want these trays to be easily reproducible and reprocessed in a timely manner. In most instances, there is not enough space for trays to sit around after each use. It will only create more work at the end of the day and the potential for certain instruments to not be ready for use the following. Again, technology. Use it to your advantage. If you are using a preoperative templating or planning software, you can be more efficient with not only your tray layout, but the implants you have available the day of. Learn to better allocate your resources and if they can be utilized elsewhere. It's a win-win. As I stated previously, we primarily use two femoral components at Innovate, a mini hip and Metafix. Knowing this, we can successfully perform a total hip replacement out of one pan. We keep 4 of these on the shelf. Prior to this setup, we would be using 3 pans and have one backup for every case. So let's say you have 4 total hips in a day, that's close to 20 trays including backup sets, not including hospital sets. This is our total hip extras. We keep 2 of these on the shelf. Again, we want to keep inventory to a minimum. If you're only using screws 5% of the time, do you need to have that set open every case? Anything that can go wrong will go wrong. Mistakes happen, but it is your responsibility. The workflow never stalls. The following is a list of what we always keep on the shelf. I want to make note, you always want to have a cable set with extra cables, a cemented stem with a prep kit. I keep a dual mobility press on the shelf. I don't keep the entire set. Stem extensions for a total knee, and then dished and PS inserts also for a total knee. Every day I'm in communication with the ASC staff and what the following day's surgical order should be. Many factors play into this. Some to consider. Are there any health issues? Does the patient have someone to pick them up? Is it a difficult case? But also workflow. It can be as simple as keeping all the hips in one room and the knees in another. The day before or the morning of, I provide the scrub techs and those pulling the instruments with implant-specific sizing and what, if any, technology is being used. One of the unsung heroes in any hospital or ASC is the sterile processing department. Communicate with them. Let them know of anything that may need to be turned over or take precedence over something else the morning of. Circling back to optimizing tray efficiency will allow the reassembly in the room more time effective. If an instrument turns up missing as the scrub tech is cleaning up after the procedure, it is more likely to be discovered then, as compared to after that, when the set has already been washed 3 times and is about to be sterilized. Immediately turning sets also ensures that if something unpredicted is needed in a case later that day, it's all ready to go. Here's an example of what our planning looks like. Sticking with the total hip theme, for the second case of the day, you'll see the patient is templated for a 52 cup, a 3 125 Metafix, and we'll be using Navi Swiss. You can also see they're even on blocks. The day before, the staff will pull the instruments required, and the morning of, the scrub tech will pull out a 50 and a 52 reamer, the reamer shaft, cup impactor, corresponding liner impactor, broach handle, broaches up to a size 4, the 125 neck, and head trials. Working together with the staff, we have made this an extremely efficient process. In summary, the ASC setting has to be a team-oriented environment. Do your best to over-communicate with every individual involved in that process. Do not become complacent. No one case is the same. When problems arise at any moment, communicate that with your team, specifically your surgeon. If they don't know about it, they can't help. And then finally, continue to involve in order to create an even more efficient and better process. We still are. Thank you.